Hi, I'm Dr. Joe Nyamtu, LoveThatFace.com, and thank you so much for watching our YouTube channel. If you watch us, you know that my passion is facelift surgery, and I love coming to work, and I feel that I'm a really lucky guy that I get to come to work and do facelifts and eyelids and facial implants and lasers and all this stuff. I only operate from here to here. I don't do boobs, bellies, and butts. And we do 2 or 3 facelifts a week. We have an international practice, and we do patients from all over the United States and outside of the United States. And again, I love what I do. Now, in consulting with people about facelift surgery, which I do multiple times every day, all day, certain things come up. And it's kind of funny because the 2 things that people kind of fear the most are scars and general anesthesia. And in all honesty, these are 2 of the things that we have the least problems with. And I want to talk today about anesthesia and facelift surgery because this is a sticky subject and there's a lot of myths out there, and let's talk about this. Now, first of all, any honest, ethical, humble doctor is going to tell you that there's no one way to do anything, all right? And what you have to do to be a good doctor and have good results is there's 2 big things. Number 1 is patient safety. Your patients have to be safe, okay? In my situation, we have a fully accredited surgery center. All my staff are certified registered nurses or certified OR techs, and we just having an accredited surgery center is a multitude of paperwork and safety precautions. So it's really like having your own mini hospital. We also have a full-time anesthesia providers, several of them, because this is all we do every day. Now, again, back to the honest doctor. If you do safe surgery, and the other thing that I was going to mention is natural results, okay? So safe surgery and predictable outcomes. If you're doing that, that's really the only important things. And in all honesty, some people do that with general anesthesia. Some people do it with IV sedation. Some people do it with tumescent anesthesia, local anesthesia with oral sedation, taking some pain pills or muscle relaxants. And some people do it totally awake with just local or tumescent anesthesia. And if that doctor is providing a safe experience and a predictable outcome, then it's really okay, all right? Now, having said that, if you went around the United States or the world, I've lectured on 6 continents, I lecture all over the world, so I'm always talking to plastic surgeons, cosmetic surgeons, different surgeons about how they do things. Most of your really well-known and busy facelift surgeons are going to be using general anesthesia. And if you go to a hospital, you're going to have general anesthesia. Now, there are a lot of doctors that can't provide general anesthesia, okay, for numerous reasons. They don't have hospital privilege. They can't go to the hospital, or they don't have an accredited surgery center, and they legally can't have a general anesthetic setup. And unfortunately, sometimes those doctors are the ones that propel these myths, like, oh, it's really dangerous, you could die, you know, all these things about general anesthesia. And in reality, general anesthesia is actually the safest way to undergo surgery. Now, it's difficult just defining anesthesia, okay? Because some people say, well, I don't do general anesthesia, I just do deep sedation. And here's the situation. If somebody gives you drugs, whether it's through an IV, whether you're inhaling that drug, whether you're taking oral drugs, if you tap on somebody's shoulder and they don't open their eyes or they're not responsive, I mean, technically that's a general anesthetic. So there's a lot of people that do general anesthesia and they just don't call it that because they're trying to do marketing. And, you know, obviously, if somebody is maintaining their own airway, if they can breathe and everything, then that's probably a sedation thing. So it's a fine line between IV sedation and general anesthesia. Now, in my office, we do general anesthesia. And why do we do that? Well, there's a multitude of reasons. First of all, I think it's very, very safe. And I've done facelifts on my sister, on my mother-in-law, on family members. And of course, if I thought it was dangerous, I would do something else. So let's talk about why is general anesthesia safe. Can people die under general anesthesia? Of course they can. And people can die under IV sedation. People can there have been fatalities from just oral sedation, and there have been fatalities from IV anesthesia as well, without general anesthesia. So first of all, anytime you're giving anybody any medicine, people die from aspirin, right? So it can happen. I tell patients, and I really do think that the biggest danger they face in their surgical experience is driving back and forth to my office. I think that your chances of having something bad happen to you are much, much higher in a car than they are in a accredited surgery center with board-certified anesthesia providers. And I feel strongly about that. So let me enumerate a couple things why I think it's important to do general anesthesia. Number one, again, if you look at busy facelift surgeons that are well known, that do a high number of facelifts, and I've done at this point 1,300 of them, you'll see that most of those people do use general anesthesia. Now that doesn't make the people that don't, that doesn't make them wrong or unsafe or anything. But first of all, it takes me, the actual cutting time when I do a facelift is probably about 2 hours, okay? I talk to people that have previously had facelifts and it was under local or tumescent or sedation, and it took 6, 7, 8 hours sometimes, all right? So when you are under general anesthesia, it's a faster situation. And I don't care what anybody says, no doctor or any patient will tell you that they can do a better job when a patient is not moving, not talking, not rustling around, or not wincing from discomfort, okay? So that absolute control of the patient is important. You're actually using less medication very frequently when you're doing general anesthesia because it's a shorter procedure. And, you know, again, I know people that do facelifts with local or IV sedation, and these are 5, 6 hour procedures, and you're using a lot more medication. We don't use any opiates with general anesthesia, or very, very little on some patients. And this is important for several reasons. Number one, that's what causes nausea and vomiting. And nausea and vomiting can lead to hematomas and discomfort, and who wants to be sick when they wake up? You know, a lot of people say, well, general anesthesia makes me sick. General anesthesia has changed a lot in the last 30 years. The medications that we have, the types of gases, we frequently use LMAs, which is laryngeal mask airway, and don't have to intubate people where you put the tube down the voice box and that sort of thing. So that's another important reason. The longer that a patient is lying down flat, the more problems they can have with compression, nerve injuries, back, neck problems. So a faster procedure is a benefit for the surgeon and the patient, all right? Probably the biggest thing is you have a 100% protected airway, because there are people that have anesthetic fatalities from aspiration. You know, patients don't eat or drink before they go to sleep, but still some people can throw up or have blood go down into their lungs and have big problems, whereas with general anesthesia, with an LMA or an intubation, you have a 100% totally protected airway. So I want to talk about a couple other things, stress, comfort, and apnea. Again, I've had patients come here and they say, gosh, my last facelift that I did, again, I did it, I was awake and I had some oral medication or a little bit of IV stuff, and I got up and I went to the bathroom a couple times, and you know, this is just not how most surgeons do this. You want to put somebody to sleep, you want to do your procedure safely, and you want to get it over with. And you know, everybody's nervous before surgery. There's no doubt about it. And the stress and the comfort is just 100% when you're doing general anesthetic. Now, when a patient is asleep, okay, and again, whether you're sedating them with a pain pill and a Valium, whether you're giving them something IV, or whether they are 100% asleep with general anesthesia, their life is in the hands of the surgical team. And there have been bad things happen with any type of anesthetics, all right? First of all, in an accredited surgery center, we can only put healthy people to sleep. That's ASA, American Society of Anesthesiologists 1 and 2. Those are the classifications. So these are people that are healthy but may have high blood pressure, maybe diabetic, or they have controlled disease processes, okay? And the mortality rate, or the morbidity rate, in other words, anything bad happening to a patient that is ASA 1 or ASA 2, is extremely low. And we have done polls where my anesthetic providers are on various little bulletin board, Facebook or Twitter type things where they routinely talk to their colleagues. And the vast majority of people that do a lot of facelifts, I'm talking about the anesthetic personnel, they perform general anesthesia. Now, the other big thing is the airway, okay? If something bad happens during anesthesia, it's frequently the patient loses their airway. And unfortunately, that's what happened to Joan Rivers, who had an inappropriate anesthetic in an inappropriate environment, and she basically suffocated. So the airway is so important, not only if you have nausea and vomiting, but just the ability to keep oxygen going through the patient. And if a patient has a laryngospasm or something like that, which can happen with oral sedation, IV sedation, general anesthesia, but with general anesthesia, there's a tube in place and that airway is 100% protected. And that is probably the biggest rationale for doing that type of anesthetic. Now, hemodynamics is very important with any type of anesthesia. The lighter the patient is, the more local anesthetic they get with epinephrine, the higher their blood pressure becomes, the more anxious they are. And it's not uncommon, believe me, I've done this for 30 years and I've been in many, many offices, and it's not uncommon when people do facelift surgery and the patient is not asleep, that the patients are jumping or grimacing, and there's just less precision, okay, for the surgeon, as opposed to working on somebody that is totally out. So it's that level of anesthesia and that level of precision, but it's these hemodynamics. High blood pressure is a bad thing for facelift surgery because you bleed more, you lose more blood, but the biggest thing is these people are more of a setup for post-operative hematoma, where you have bleeding under the facelift flap. Usually happens, in the first evening after surgery, and you've got to come back to the office or back to the hospital or back to the surgery center and open those incisions up and drain that hematoma. With general anesthesia, we can raise and lower and control the blood pressure throughout the whole case. So those stable hemodynamics are extremely important. Now, let me tell you this. I can have people that are going to argue with me up and down and back and forth. And like I said when I started this video, if you're doing safe surgery and having predictable outcomes, natural outcomes, happy patients, then you're probably doing it right. And for some people, that may be local, it may be oral, it may be IV. For me, it is general anesthesia. And I don't care what people do as long as they do it safely and correctly. And I think with anything, you should always try and make it better for the patient and the surgical team, and we constantly strive to do that. So one of the really common things that people are afraid about with general anesthesia is waking up while they're asleep. In other words, they're paralyzed, but they're not anesthetized and they can see and hear and feel what's going on. And you see that in the movies and you hear about it in the media. That is extremely rare. In my 35 years of doing tens of thousands of surgeries and anesthesia, I have never had that happen or seen it happen. And an astute anesthesiologist or nurse anesthetist, they're continually watching the vital signs. And if somebody is waking up, they should be able to see that, okay? And you can also measure brain waves, and some people use separate monitors for that. And of course, that's just something that's obviously really scary, but I think that's more of a Hollywood thing. Not to say that it's never happened, but I've never seen that happen in an accredited surgery center with skilled personnel. Another question that frequently comes up is, post-operative nausea and vomiting, which it's not uncommon for people to come in and say, gosh, they hate to go to sleep because they've had big problems with nausea and vomiting. Well, I can tell you this, when I started doing this decades ago, that was a really common problem. But as medications and anesthetic drugs have improved, as well as nausea and vomiting medications, we just don't see that. I can't say that we never ever see it, but it's pretty rare. And people that do have a history of postoperative nausea and vomiting, they're treated in a little bit different way in the practice. So one of the things that we do is we use a preoperative scopolamine patch on them, and that's a little patch like you wear when you go on a cruise ship, and that helps stabilize them for nausea and vomiting. maintaining their hydration in anesthesia is a very important part of it. And my anesthetists, they're very good at heading this off, and they don't use opioids. They may switch, once the patient's asleep, they may switch to IV drugs instead of inhalation drugs. And there are so many things that have to do, and I'll tell you, it's complex, so I'm just going to read some of them to you. But known triggers for nausea and vomiting include presynaptic and postsynaptic nerve situations, proton pump inhibition, gastric motility control, cell membrane stabilization, 5-HT3 antagonism. Okay, that little list is from my anesthesia provider, and that's what they take care of. So it's not that it's impossible, but when it's addressed, we certainly can do better. And the nausea drugs that we have now, they are so much better. Zofran is a drug that we give to people for postoperative nausea. They usually don't use it, but we give them a prescription, and that even works well for patients that have severe nausea and vomiting on chemotherapy in situations like that. So I know this has been a long video, and it's a very controversial subject. And listen, there's many, like I said at the beginning, there are many surgeons that maybe they do local, maybe they do tumescent, maybe they do tumescent plus oral sedation, maybe they do total IV sedation, maybe they do general anesthesia, and they have great results and they have happy patients. This is not the only way to do it, but I think it's a very, 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 very common and the most popular way that it is done. And it's my explanation, because so many people ask, do you really need to go to sleep to a facelift, for a facelift? I hope this has been enlightening, and I know it might be controversial, but thank you so much for the greatest gift of all, which is your time. I'm Dr. Joe Nyamtu, lovethatface.com.